think what keeps me up at night most is when we have patients that I can't help with the system that we have established. And
so I think in terms of research, it's your data, that are really critical. And so making sure that there aren't any breaches in terms of your data, in terms of confidentiality, keeping everything very secure. And
providers often are unsure how to prognosticate or to predict how infants will do in the long run. So giving information to parents can be really difficult.
And the other issue that really bothers me is health disparities. A lot of things play into what happens when you get health care. I think that there are a lot of other things that go into it. For example, the concept of cultural competence. We can talk about being culturally sensitive, we can talk about working in a multicultural environment, but really cultural competence to me is something that you strive for. You don't get there. There's no way in the world I'm going to be culturally competent with all the cultures that come through here. But I do have to be able to recognize that I need to ask people what it is they need, listen for the unspoken things, and work toward making sure that they get what they need on their terms, not mine, theirs.
Just that we come to the work prepared to see pain and suffering. And so there are times when it seems like too much, it probably is too much.
So I think breaches in trust with students, sometimes that comes through when you see that they've perhaps submitted work inappropriately. Where I haven't had a lot of issues, but sometimes there are questions about plagiarism.
We have a lot of technology in cardiac surgery, and we use that to save people's lives. But sometimes the patient doesn't necessarily want all of that technology, and sometimes they express that, especially to nurses, I think, at the bedside. Or sometimes they will express it to them, but what they say to their family or to the interdisciplinary team is different, and they agree to certain things because they think their family or their significant others want them to do that, or the team thinks they should do that, but it's not necessarily what they want.
They're actually varied. Because I'm in an administrative role, I would have to say that adequate staffing.
The reason it's prolonging suffering is that I think we all know that it will inevitably end in death, and we're just really prolonging the inevitable, and that is very ethically challenging and very draining to take care of those kinds of patients, and those are the kinds of patients where you leave just feeling very sad and like you really didn't help them, you just hurt them. And
with all of that going on, sometimes I think it's easier just to not deal with the ethical issues, to avoid going there. And it takes a lot of courage to bring up the topics that nobody wants to talk about.
I think that one of the things that we seem to see as a challenge that maybe keeps coming up is when the team itself, our whole team, isn't on the same page. We don't have a consensus of how to treat those patients. We do genetic terminations.
I think the primary one is the issue of HIV disclosure, so disclosure of positive status. I think
people's main focus is, what can we do to keep this child alive? What is everything that needs to be done to keep this child alive? Rather than, if we keep this child alive, what quality of life will he or she experience? And if he or she will not have any quality of life, then what can we do to address the needs of a child in a way that is compassionate and humane?
One is also personal bias. When one's personal feelings affect how they deliver care to the patient.
That things keep me up at night when I don't feel I can deliver, safe, effective, patient-centered care. If I'm not able to help them in the best possible way I can, it really does. It breaks your heart.